All right, in this lecture, we're going to be talking about the regulation of fluid pools. So we're going to look at the volume of different fluids in different regions of the body, so intracellular, extracellular, and how we respond to changes in the amount of blood volume and the amount of blood pressure, as well as look at ion and acid-base balance, so maintaining proper levels and proper concentrations of different ions, so like sodium and potassium, as well as talk a little bit about acid-base disorders and how maintaining certain levels of acid in the blood is necessary for proper function, as well as maintaining various concentrations of bicarbonate in the blood to maintain pH there as well. So starting off, we can look at volume and osmolarity in terms of different types of receptors that can detect changes in pressure. And so we have what are called high pressure sensors or sensory receptors and low pressure sensory receptors. And so one's like in the carotid sinus, which is this kind of space in this region here, so this kind of region at the bifurcation of the common carotid artery. The aortic arch, so in the arch of the aorta here, as well as in the renal afferent arteriole, so that vessel leading into the glomerulus. These are all high-pressure sensors. So these are detecting increased distension, increased volumes of blood, which then reflect increases in blood pressure, right? And then these other ones, so the atrial stretch, the juxtaglomerular apparatus, or the JGA, and then regions in the CNS and the liver. These are low-pressure sensory receptors. So these are detecting decreased volume, decreased distension, and decreased pressure, decreased blood pressure in the blood. And so the interaction of these different high pressure and low pressure sensors, these reflect a change or a monitoring of a change in blood volume, as well as blood pressure. And so maintaining proper blood volume and thus maintaining proper blood pressure, this is what's known as hemodynamic control. So hemo is referring to blood, dynamics are referring to the changes in that blood. And so we're trying to regulate that and trying to control it and keep it within a certain homeostatic range. So we'll talk about something in a second called the Renin-Angiotensin-Aldosterone system that helps to maintain this control very nicely. All right. So one thing we can look at is the plasma volume. So just look at how much fluid there is in the fluid part of the blood, how much there is. And so one thing that can happen is in the kidney, as you stretch the afferent arteriole, or if there's a lack of stretch, this can be detected by that juxtaglomerular apparatus, so the JGA, and there are granular cells in this JGA that release something known as renin. All right. And we'll talk more about renin in a little bit, but the renin will ultimately lead to an increase in sodium reabsorption, increase in water reabsorption. All this leads to an increase in blood volume, which increases blood pressure, right? And so renin will then act on a couple of different compounds called angiotensinogen, convert this into something called angiotensin 1. Angiotensin 1 gets converted into angiotensin 2, which you can see right here. And then angiotensin 2 stimulates the release of aldosterone from the adrenal gland. It stimulates sodium reabsorption, and it stimulates water reabsorption via the effect of both aldosterone and antidiuretic hormone. And again, all these are serving to increase blood volume, increase blood pressure as well. All right. Now, you can also have osmoreceptors, so detecting not changes in necessarily the volume of blood, but detecting the changes of the things in the blood, right? So looking at the osmolarity or the concentration of things in the blood, right? And so in our hypothalamus, this is what you can, we've referred to the hypothalamus before, but you can essentially think of the hypothalamus in this context as being the thirst center, right? And so if you have a decrease in osmolarity, you're going to have an increase in the concentration of the. I'm sorry, if you have an increase in osmolarity, you have an increase in the concentration of solutes in the blood, right? And so if you look over here on the right, we have an increase in osmolarity. So that means there's lots of solutes in the blood, meaning it's very concentrated, right? So there's more solutes relative to the amount of water. And so in this case, there are osmoreceptors that are going to stimulate a nucleus in the hypothalamus called the supraoptic nucleus, which is going to then begin to secrete antidiuretic hormone, or ADH, right? We've talked about ADH before. This acts on the distal tubule. It acts on the collecting duct to insert aquaporin channels. If you insert aquaporin channels, you get reabsorption of water. And so here we get increased water intake, and we are able to return to a slightly normal kind of water level, and that then equates to a normal osmolarity, right? You'd have the opposite happen if you were if you had a low osmolarity, so you were very dilute, right? And so in this case on the left, here we're very dilute, lots of water, relatively few solutes. So what we don't want to do is we don't want to continue to reabsorb water. And so the kidney will retain more water. So in other words, we'll get rid of more water in the urine. We will not stimulate our thirst center in the hypothalamus, so we'll have decreased water intake. Will ultimately lead to an increase in the amount of water that is excreted in the kidney, and this will then return our plasma or our blood osmolarity back to normal, right? So you have this interaction between solutes, and you have this interaction between solutes and water, and depending on where you're at in your osmolarity, you have a high osmolarity, you have a low osmolarity, you're going to increase or decrease the amount of antidiuretic hormone, which leads to an increase or decrease in the amount of water that's reabsorbed or retained in the kidney, and then that's ultimately going to result in a change in serum osmolarity, right? So all this, keep in mind, all of this is serving to maintain a normal volume of blood, right, and a normal osmolarity of blood, so normal concentration, right? So we can also then look at our ions and acid base, right? And so sometimes ions are going to then influence volume, so namely like sodium. So we can look at these, and we can look at two in particular, sodium and potassium, right? And so sodium is existing in the blood in a normal given range, right? So if you have too little sodium in the blood, this is referred to as hyponatremia. If you have too much sodium in the blood, you have hypernatremia, right? And so anything below like 135 milliequivalents is about the kind of threshold of being hyponatremic. Anything above 145 milliequivalents is on the threshold of being hypernatremic, right? So you have this very thin threshold, this kind of narrow range that you'll learn if you do something like nursing school or medicine. You'll learn these different ranges, and proper functioning of cells, of neurons, maintaining proper blood volume. All of these are dependent on having a certain amount of sodium in the blood, right? And so if you have renal disease, you may excrete more sodium than is necessary, so you have low sodium levels. If you have too much or too little antidiuretic hormone, this can also influence the amount of sodium. So if you have diabetes insipidus, which is a decrease in the amount of antidiuretic hormone, you end up getting rid of, excreting, getting rid of more water, and so this causes the serum sodium concentration in the blood to then drop. And then if you had something called syndrome of inappropriate antidiuretic hormone, or SIADH, you have too much antidiuretic hormone, so you retain more water, and so the sodium ends up becoming very dilute, right? So you have these differences in different conditions that can result in changes in sodium concentration. The big thing for sodium is alterations in the nervous system, alterations in the central nervous system. So this can have to do with brain function. It can have to do with nerve conduction, like nerve impulse conduction to muscles. In patients, you can see this as changes in their mental status, so they may become confused and disoriented, all as a result of changes in their sodium concentration, right? Now, you can also look at potassium, right? And so potassium is also existing in a very kind of narrow range, a very narrow threshold of different ions. It's anywhere from 3.5 to kind of 5 or 5.2 milliequivalents per liter. And so anything below that, anything below 3.5 is considered hypokalemic or hypokalemia. Anything above that is considered hyperkalemia. hyperkalemia, right? Big thing for potassium is muscle function, right? Muscle function, including heart function as well, heart abnormalities. So changes in potassium levels drastically influence the conduction and the contraction of the heart. Potassium is one thing you'll learn if you go into nursing, that it is a medication that you do not give IV push. So in other words, you do not give it fast. If you give it fast, you can alter the extracellular concentration of potassium, which can make it more difficult for a cell to depolarize, and this can lead to cardiac arrest. Right. So you do not give potassium IV push. You do not give it fast in patients. Right. And so when looking at acids now, or acids and bases, acids by definition are a compound or something that donates a hydrogen. It donates a proton, right? And the hydrogen in this case is serving as the proton. An increase in the number of protons and the number of hydrogen ions leads to an increase in the acidity level, and that means a drop in the pH. So a lower pH means a higher acidity level, right? And so if you have more carbon dioxide in the blood, carbon dioxide goes through a number of reactions that we'll look at in a second that leads to the formation of protons, and so more carbon dioxide, more protons. You can also have metabolic acids in the body. You can also have inorganic acids as well, so different types of acids like sulfuric acid, things like that, right? These are not necessarily in the body, but they can be introduced, but they're all acids, and the idea of the acid is that it's going to donate a proton, right? Now, if you go on the flip side and you look at a base, the base is going to be something that accepts a proton, or in other words, takes a proton out of solution, right? So it's going to decrease the concentration of those. So this is something like bicarbonate, right? So bicarbonate can combine with protons to form something called carbonic acid, which is a weak acid compared to other types of acids. And this helps to increase the pH, which is decreasing the acidity level, right? And then you can have buffers, right? And so buffers are compounds that help to kind of minimize the large-scale changes in blood pH. So you have buffers called the phosphate buffer system, which is using like dihydrogen phosphate. You can have the protein buffer system, which is using different ends of an amino acid to help buffer, and you can also have what's called the carbonic acid bicarbonate buffer system, which is using both bicarbonate here. It forms with hydrogen to form carbonic acid, and I think we have a picture of that in the next slide. Yeah. So this system right here in the lungs, this is the carbonic acid bicarbonate buffer system. What it does is it combines. You can go both ways, really. You can go both ways. This is going specifically from left to right because we're in the lungs. But you can go from right to left as well. And so what you're doing is if you have carbon dioxide and water, if we're going from right to left, this forms this middle compound called carbonic acid via an enzyme called carbonic anhydrase. And then you keep going to the right, and then this dissociates into a hydrogen and a bicarb. Well, you see here, we just released a proton. We just released a hydrogen. So if we went from right to left, this is increasing the acidity level or decreasing the pH of the blood or of a solution, right? If we're going from left to right, we're doing the opposite, right? We're combining the hydrogen with the bicarb to form carbonic acid, and then the carbonic acid dissociates into carbon dioxide and water, and you breathe that out in the lungs, right? So depending on which direction you go, you're altering the pH, right? If you're going from right to left, you're increasing the acidity level or decreasing the pH. If you go from left to right, you're increasing the pH or decreasing the acidity level, right? Now you can also have some buffering take place in the kidneys as well, right? And so depending on the acidity level of the blood, if the blood is acidotic, if it's alkalotic, you can have changes in the amount of hydrogen and bicarb that are either secreted or reabsorbed. And so we've talked previously about bicarbonate reabsorption. You don't really reabsorb it, you more kind of replace it. But if we are alkalotic in the blood, right, our blood pH is too high, we're not going to be concerned with reabsorbing more bicarb because bicarb is essentially a base, right? It's a base that's going to help increase the pH. But if we're already alkalotic, we don't want to increase the pH, right? So we'll result in a loss of in the kidney. If we're acidotic, we'll then secrete hydrogen ions into the tubular fluid, and then that will ultimately become urine, thus decreasing the acidity level or increasing the pH, right? So keep all this in mind, depending on the physiological needs of the blood, depending on the needs of the body, you can have some changes in the amount of hydrogen ions or the amount of bicarbonate ions, right? So you can see things like this if we're either in acidosis or alkalosis. If we are in acidosis, you can see that this reaction is forming, if we come over here, we would have formed that carbonic acid, and then that splits into bicarb and hydrogen, and we're pumping the hydrogen into the tubular fluid, getting it out of the blood, and it's essentially coming from the carbon dioxide, right? And this is going to help decrease the acidity level or increase the pH of the blood, right? We're also reabsorbing more bicarbonate in here as well, which is going to help. Or if we're alkalotic, we're doing the exact opposite, right? And so in this case, we are forming carbonic acid. This dissociates into bicarb and hydrogen. And in this case, we're going to reabsorb more hydrogen, thus decreasing the pH or increasing the acidity level. And we're also going to secrete and excrete more bicarbonate, and both of those things together act to decrease the pH, which is increasing the acidity, right? And so you can see this reaction and how it's taking place, right? So the only thing that's kind of missing in this middle region here is the carbonic acid. And so if you're going from right to left, if you're going from left to right, this would be increasing the acidity level because we're donating hydrogens here. If we're going from right to left, this would be decreasing the acidity level or increasing the pH because we're getting rid of this hydrogen. So going from right to left in this case, this would be what would be happening in the lung, but this is showing what is happening here in the kidney, right? So you can have these different disorders depending on which molecule is changing. So is it bicarbonate? Is it CO2? If you're acid, and this is referring to in the blood specifically. So if you're below 7.35 in the blood, you're considered acidotic, right? You can have respiratory acidosis or you can have metabolic acidosis. If it's respiratory, it's largely an increase in the amount of CO2, right? And as we saw in this slide, right, if we're increasing the amount of CO2 here and we're going right to left, so more CO2 ultimately leads to more hydrogen, which is acidic, right? If it is metabolic, you're producing other types of acids, so like maybe lactic acid or something like that. If you have like ketoacidosis and diabetes, things like this, these can all lead to a decrease in the pH or an increase in the acidity level. If you're alkalotic, you're going to be above at 7.45. So anything in between 7.35 and 7.45 is considered normal. Now anything above 7.45 is going to be considered alkalotic. So if it's respiratory, that means we have too little CO2, right? So for the same reason, if we have too little CO2 here, we're going to have too little hydrogen ions or too few hydrogen ions, which is going to increase the pH. Or if we have metabolic alkalosis, we may be altering the amount of acid that's secreted in the body. You may have vomitus. You may throw up, be throwing up acid, which is decreasing the acidity level or increasing the pH, things like that, right? And so you can look at graphs like this and see the relationship between the pH of the blood and the bicarbonate in the blood. And you note that as you increase the pH of the blood, you're slowly increasing the amount of bicarbonate. And there are differences in the kind of rate of increase of bicarb that determines whether you're metabolic or respiratory, if you're alkalosis, if you're acidosis. But you can see these relationships here. So as we're increasing blood pH along this x-axis here, along the y-axis here, the arterial plasma bicarbonate concentration is going to also be increasing, right? So if you take something like metabolic alkalosis, right, you're increasing the blood pH here. We're at 7.5 or so, and we've drastically increased the amount of bicarbonate in the blood. And there's certain homeostatic ranges for bicarbonate in which if it becomes too high, the plasma becomes too basic, too alkaline. If it becomes too low, it becomes too acidic, so on and so forth, right? So last thing that we'll discuss here is the regulation of the blood pressure with the RAAS system. So the RAAS is essentially the Renin-Angiotensin-Aldosterone system. And what it's doing is it's serving to regulate our blood pressure, right? And so typically you can think of this happening whenever we have a low systemic blood pressure, right? So this is where we're starting. We're starting in this region up here, low blood pressure, right? That low blood pressure results in a decrease, temporarily a decrease in glomerular filtration in the kidneys, right? This can be sensed by the granular cells of the juxtaglomerular apparatus in the kidney, right? Kind of in that distal convoluted tubule region. This renin is going to result in the formation of something known as angiotensin 1 from angiotensinogen. So anything that ends in ogen like this, that means it's inactive, right? So you form angiotensin 1. Angiotensin 1 is converted to angiotensin 2 via this thing called ACE, right? ACE stands for angiotensin converting enzyme, right? You may have heard of ACE inhibitors. You may have a parent, an aunt or uncle, a grandparent that takes an ACE inhibitor. They all end in pril. So like lisinopril, things like this. These are ACE inhibitors that are serving to inhibit this enzyme, right? So if we convert angiotensin 1 to 2, angiotensin 2 does a lot of things, right? So one, it's going to vasoconstrict. So if you look at the word angiotensin, angio refers to blood vessel or vessel. Tensin is referring to tense or constrict, right? So angiotensin 2 literally causes vasoconstriction, right? Which is going to increase resistance, which increases pressure, right? It's also going to result in aldosterone release, right? From the zona glomerulosa of the adrenal cortex of the adrenal gland. More aldosterone, more sodium reabsorption, more water reabsorption, increased blood volume, increased blood pressure, right? You can also release ADH from the pituitary gland. ADH causes increased water reabsorption, which increases blood volume, which increases blood pressure. And angiotensin 2 also stimulates the nucleus in the hypothalamus where our thirst center is. And so it stimulates our thirst reflex to increase water intake, which increases blood volume, which increases blood pressure, right? So you can see here how if you were taking an ACE inhibitor, which kind of block the action of this ACE enzyme, if you block this ACE enzyme, you're then blocking all the downstream effects of this, right? So you're going to have less vasoconstriction, less ADH and aldosterone release, less water reabsorption. You're going to have less thirst sensation, so you'll drink less, you have less blood volume, and thus less blood pressure. So ACE inhibitors are blood pressure medications that are taken by individuals who have a high blood pressure that need to have something to help bring that down, and they do that by blocking this the formation of this angiotensin 2. All right, so we'll end here. If you have any questions about this lecture or any of this material, feel free to reach out, and I'll be happy to help.